but I'd obviously still like to open the floor up for questions or comments to the three, particularly to the three speakers who are present here now. I know this is a risky business in Zoom because often you're hit with a wall of silence. Is there any particular comments or questions to the speakers?
So we had 4 presentations. I request the participants, we can go one by one. We have a brief 10-15 minutes. We are running ahead of time, and just my thing is, with regard to the first presentation by Dr. Shona, so in your slide there was something mentioning about the visualization. I have also read in your paper, that Uzbekistan paper. So what is that visualization component which you are talking when they were taking the drugs? That is first question. And then you mentioned about TB treatment has been historically paternalistic. Okay, so if you could just elaborate on these two concepts, it will be good. Yeah.
Thanks for the questions. So the first one, in terms of visualization, that was partly about seeing the treatment as something that's more strength giving. So actually people describe trying to visualize the drugs as swallowing something that is giving you strength, or swallowing something sweet like a grape, rather than visualizing something that's going to give you horrible side effects and make you feel really nauseous. So actually trying to employ some of those kind of techniques could actually help people be able to physically tolerate the drugs. Because one of the things people described as being most challenging was, and interestingly, again, highlighting some of the difference between the kind of international perspective and this perspective of people affected by TB. While obviously injectables are really problematic because of the horrific side effects, including permanent hearing loss, for people affected by TB in Uzbekistan, actually the main thing for them was having a reduced oral pill burden because of that physical act of having to swallow pills. So yeah, those kind of techniques were the things that people felt could help. The TB paternalism, so that's having the kind of more, what was also described by one of the other presenters as the one-size-fits-all type of approach, where things are more controlled, regulated, primarily looking at, so some of the history of infection control, where that might be prioritized over the kind of health of the individual affected by TB. So when we had TB sanatoriums in the past, things like that. So sometimes that can prevent this more, having a more flexible or adapted approach. And interestingly, things like what we've seen in HIV with differentiated approaches to treatment and care, I think that's really demonstrated how it is possible to have an approach that's flexible and adaptable, but that is delivered at scale, because that's one of the hesitations has also been when you have large patient cohorts, how can you have an approach that's really adapted, individual and flexible? That is possible. And while I'm speaking, I'd also just like to take a moment to highlight how interesting it's been to hear the other presentations, because actually one thing that struck me was how many similarities there are in terms of some of the themes and the issues that affect people with TB in so many different regions of the world, that actually there is that kind of shared experience that I think is important to highlight and to reflect upon, particularly in terms of the need for real strength, perseverance, the difficulties that people face. And I was interested to hear from Dr. Hannah Marisol that how if we can reframe some of the approaches to infection prevention, actually that can be something that people feel more positive about, rather than things like respirators being something that can exacerbate a sense of shame and isolation. Because one thing I didn't mention in my presentation, but when I talked about the kind of misunderstanding of infection, transmission risk, and the limited awareness of infection reduction strategies, people were quite confused because there was a difference between what was said and what was seen. People were told that once you're on treatment, you're not infectious, but actually they would see that health workers are still wearing a respirator around them. So why is that? If you're telling me I'm not infectious, why are you wearing a respirator? So I think that was quite important to highlight as well. Thank you.
Thank you, Dr. Shona. Yeah. So I would request the participants to shoot your questions. for Dr. Shona, Dr. Jens, Dr. Leon. Dr. Prashant is here. Interesting. And I know with Dr. Jens, in your slide, you were discussing about systemic, determinants of antimicrobial resistance. Can you elaborate on those? I have read some papers where you have, especially about those, pharma and provider nexus.
Thank you. What we have seen in the past in TB treatment in countries like India, where there is a very big private sector, healthcare sector, there is a vast variety of TB treatments being adopted. And many of those drivers of these varieties have also to do with the way, for example, chemists and private practitioners are incentivized by economic structures and so on. So these go together in the specific treatments that patients eventually receive. And those dynamics are quite similar, actually, for tuberculosis and for other infectious conditions, because of the vast proportion of private treatment, privately provided treatment. So I think in the past, and for good reasons, of course, the emphasis has been on the DOTS program and on the government programs. But in countries where there is a huge private sector, I feel there is a need to look at those dynamics a little bit differently. So I think that an approach that tries to map out these dynamics could be really helpful. I don't know if that at least answers some of the implications of the question. Also, sometimes what we have seen is that, for example, a physician working in a hospital, in a government hospital with TB patients, would refer those patients to his or her private clinics. And that, of course, takes patients away from a context where treatment is free and within a particular regimen, which is controlled and defined by the government, into a less controlled or more fluid area where the provider has an ability to earn money from a treatment that ought actually to be provided for free. So there are all these kinds of complex dynamics which I think are important to factor into TB control and reduction of the risk of development of drug resistance.
Thanks, Jens. There's actually another question for you in the chat as well, which asks about whether you could talk about the concept of configuration and its relevance to TB control.
Yes, I can say a little bit following up on what I just said, because I believe it's important to try to understand the world as seen from the patient's perspective, and that world does not only include the healthcare providers. It certainly does, but it includes a wide range of healthcare providers, from the chemist to the, as I just said, the private practitioners, various kinds and various levels of qualifications of providers and hospital settings, diagnostic facilities, labs that the patient may not be sent to by various healthcare providers. All of these tap into the household economy in various ways. For example, there's a tendency that that the prescriptions that TB patients get from providers may contain up to 5, 6, 7, 8, 9, 10 drugs. Many of those are not TB drugs, and many of those may be unnecessary from a strictly medical perspective, but they do become part of the economy. They do become part of the industry that's also making money from them, but they tap into the household economy of the patient. They tap into the social network that the patient depends on in order to be able to manage a situation where he or she is not able to work, or not able to work to the extent that was the case before the disease. So what I'm saying is that the configuration tries to capture this complexity into a concept that points to the need to put together all those elements in a consolidated understanding of the dynamics and the pressures that the patients are under, that will also influence the patient's ability to go through with the treatment, either for drug susceptible TB or for drug resistant TB, because these processes add these concepts to point to these dynamics.
Well, I hope that was a question from Pearl Maria de Souza. I hope that was helps to answer that answers the question. I think it does. Is there any other comments or questions?
Myself, Dr. Karunya from NIRT. So I have a query to Dr. Lien. So it's thank you, ma'am, for sharing your valuable work with us. And in the work, actually, I found there was a note by one of the participants about the cash transfers or benefits to the TB patients. So the government, they feel that these cash transfers are not that much helpful. So they are providing food for the patient. But whereas there are many studies actually worldwide globally which says that cash transfer seems to be beneficial for TB patients. Here in India also we follow direct benefit transfer. So I would like to know your take on it. What was your conclusion over the cash transfers in your ethnography, and how do you see this in the low and middle income countries?
Thank you for your question, Karunya. Yeah, that was a very interesting part of the research. I think cash transfers can be very beneficial for those who are unable to buy food, for instance, which is so necessary to deal with side effects of the tuberculosis medication. Although for some people, we should also consider these unintended consequences of such social interventions, of course. And in this particular situation, alcohol was a huge problem within this township. And it was also a way of dealing with all this adversity. As Kulish explains in the video, is that she feels so vulnerable and unable to deal with her situation, that alcohol is also a way to cope at that certain moment with her whole situation. And I do not say, or I wouldn't say that these cash transfers have only a bad influence, but that we should also recognize such consequences and deal with those, because in a way, you could see cash transfers as a way to deal with the consequences of poverty. But the real problem we are dealing with, of course, is this huge disparity of socioeconomic status between people. And well, as you all know, as experts in the field of tuberculosis, is that tuberculosis is the disease of poverty. So unless we also focus on these bigger structures of inequality, I think it's going to be very difficult to get rid of tuberculosis, of course. So yeah, it's very complex, obviously. Yeah. Is that a good answer to your question?
Yeah, thank you.
So Dr. Leon, just one methodological clarification. So that was a very powerful video of yours. It brought out the issues and the the pains of the patient so powerfully. In the first presentation, Dr. Shona was reading out the FGD experts. That was very moving, and your presentation actually brought out the just face to face the experiences of patient. So it is, I have done some qualitative studies. It's very challenging to conduct a very qualitative in-depth interview even. It takes a lot of time to establish the rapport and bring it out. And from your presentation, I saw the way the participants were, sharing their experience were very natural, and, it was purely transparent. How was it possible for you to achieve such level of perfection in establishing the rapport? So how much you were able to prepare yourself and the community, or it was just a random thing? So just I want to know, about this visual ethnographic method. It's so powerful, actually. Yeah.
Well, thank you so much for your kind words. Yes, I really wanted to show the person behind the patient. Sometimes that is lost in all these studies you find online and all these articles and in science. So I actually had this great luck that I approached one of the anthropologists of the Cape Town University, and he did, I knew that, of course, in advance, he conducted already research in this particular township. That's why I approached him, because I realized also because of all the violence in this township that I needed some social network for safety as well, and also to get introduced into this community. And he linked me to Monua BC Makoki, the man you see in the film as well. And he was my research assistant for 6 months. And he had a very central position in his community, also as a pastor. And he was a very beloved person. So thanks to him, I started off with his wife also had tuberculosis. Unfortunately, she passed away during my research. And I started my fieldwork actually in their home. So, and I was there every day, and I was there at different time points, in the evening, in the morning, in the weekends, during the week. And I got to know their neighbors and the people around them. And yeah, by being there so much time, I really got to know them. And it wasn't all the time about tuberculosis. It was also about who they were, about their lives, about all their struggles they dealt with, but also all the positive things. It was in a way, I mean, it's labeled as the most violent township of South Africa, but it was so friendly as well, and I felt so much at home. So it was very a double kind of feeling that I got there. And I only started asking some of my respondents after 1 month if they were interested in the visual part of the research. When I got to know them and I realized whether it was, whether they were good people to participate in this for this film, because you want people who can. I wanted it to be ethical, right? That people really participated if they had a full understanding of the consequences of what it entailed, if they could also express their feelings in a way that would be, that would be comprehensible for the viewer of the film in the end, to get the message of what it means to have tuberculosis across with an ethnographic film. So I would say that's the strength of the anthropologist, that you really work on those relations with your respondents. You really build intense relationships, friendships, I would say, at some point. yeah, it's I think it's a beautiful kind of research.